Good afternoon, everybody. I will present on behalf of EMPIRICAL Consortium the preliminary result on causes of death in infants that are enrolled in the EMPIRICAL trial. The EMPIRICAL trial is an EDCTP-funded project enrolling infants living with HIV and hospitalized with severe pneumonia. I will not present any result of that trial because it's ongoing. It's just a sub-study on the causes of death. I don't have any conflict of interest to declare. And the first thing that I would like is to request a moment of silence and to show respect for those children who died during the EMPIRICAL trial and their families. As you all know, mortality among infants living with HIV, especially those that have advanced HIV, is very high. However, the causes of death are not very well understood. I'm pretty sure that this graph is very familiar to many of you. Is the pie on showing causes of death in children aged under 5, not only HIV, all children worldwide, are estimated, usually published every few years, but groups like GBD or UNICEF. They are showing different causes of death. The problem with this is that they are estimates, and they are not real data. And this is a problem because those countries where the mortality is the highest, they don't have good data on causes of death. And on the other hand, they only report one major cause of death per child. And children, like children with HIV, they are very fragile and usually they have more than one condition that are contributing to death. The conclusion is that these estimates are usually not very accurate, and they are not very helpful when we are trying to understand the causes of death in children as HIV children. And as an example of this, this is the two main groups publishing this kind of data, MCEE and GVD, and if you have a look of how the number of deaths that the reports related to HIV, the difference estimates. So it's a real problem. To solve the problem of assigning only one cause of death, this dogma of one child, one cause of death, the WHO is trying to establish a kind of guidelines to implement a death certificate where different causes of death could be assigned for a case. That was recommended to be filled at a facility level or at any clinician managing a child who died, with the idea to put in the lower line, as I put here as an example, malnutrition, the underlying cause of death, which could trigger other conditions that could be pneumonia or other that we call morbid condition that could lead to a final immediate cause of death. In this case, as an example, I put a child with malnutrition that could have pneumonia, and that pneumonia could trigger in a final immediate cause of death that is sepsis. So somehow this kind of death certificate will make the entire chain, so will make clear the entire chain of events leading to death in children. However, this kind of death certificate is not very well implemented first, and the second, doesn't solve the problem of what happened with those children that at home or dying in a place where there is no clinician filling this death certificate. So we have still this gap. In EMPIRICAL, which is a trial I will explain later the method, but it's a trial that enrolling infants living with HIV with hospitalized with severe pneumonia. In this sub-study, we are trying to assess preliminary causes of death in those children who died as part of this trial, trying to compare causes of death during the hospitalization where the child was enrolled versus the causes of death after discharge of that hospitalization where the child was admitted, and trying to understand the chain of events leading to death. Not only one major cause of death, it's just the chain of events. I guess that some of you know EMPIRICAL, but this is a trial EDCTP funded, it's still ongoing, so we don't have any result. We hope to bring here next year some results of the trial. It's a clinical trial enrolling infants living with HIV below 1 year, beyond the neonatal period, that has severe pneumonia that are randomly allocated to these 4 different arms: TB treatment, valganciclovir, combined TB treatment plus valganciclovir or standard of care. And the idea is to understand the effectiveness of this empirical treatment to reduce mortality. And we will not talk about that. We will talk probably next year. It's operating in 22 hospitals in 6 Sub-Saharan African countries. We have people working on empirical in this audience. And we started just during the pandemic, and we finished the enrollment in January this year, but the follow-up is 1 year, so we are still following some of those children. And in this sub-study that I will present, we are registering all deaths that are happening during the empirical trial during the whole enrolling period. That is almost 4 years. And how we did it. The site clinicians, so those clinical people managing the patient, are abstracting information, especially antemortem information, everything that is available in a specific questionnaire, somehow standardized, adding clinical data, lab results, anything related to the child, including the cause of death given by the managing physician, and any other information surrounding the death, because some of those children will die at home, and any kind of information is useful to determine the cause of death. What we did is, individually, 2 different experts review all the information available for each of the cases and assign the cause of death as the way that I explained before, the chain of events. Any discrepancy was reviewed by a 3rd expert. And the methodology is what I explained, the recommendation for the WHO, a main underlying cause of death. All child should have at least one underlying cause of death, and if one more condition was identified, the whole chain of events was documented. And if we didn't find any cause of death, that was classified as undetermined. And especially related to HIV, it's very easy when you are working I'm working in causes of death and codifying mortality to decide HIV is the underlying condition. But here, all children were HIV. So we were trying to analyze a bit, to have more granular data, to analyze a bit deeper the HIV condition, considering HIV complication. HIV resulting in Western syndrome, HIV resulting in TB, in multiple infections as the underlying, and not only HIV. And the result for the enrollment period of empirical, we enrolled 563, which is a very successful figure. We excluded 3 of them because enrollment in error that we realized after randomization. Among them, 44% died, which is very, very, very high. And among those who died, most of the cases, we received information to analyze the cause of death for almost all. Only one case, we didn't receive any information. And among those that we received information, that was 245, 57% died during their admission where they were enrolled, and 43 died after discharge. These are the baseline characteristics overall, and also in these 2 groups, first admission or dying after discharge. There were no difference in sex. There were differences in age at the time of death. That makes sense, was somehow expected, because children that died in the first admission were younger than the children that died after. Surprisingly, most of them were new diagnoses of HIV, around 75%. There was no difference in weight under enrollment. There were no difference on weight for height. All of them were somehow young infants and with somehow low weight, but there were no difference between groups. Oxygen saturation at enrollment was significantly lower in children admitted dying during the first admission. That makes sense, because all those children had severe pneumonia, whilst the other children had other conditions. The children died in the first admission, died quite soon after the admission, 3 days, whilst children dying after discharge, dying 78 days from enrollment. The CDC4 was not different between the 2 groups, was around 13%. And there was also no difference in viral load between the 2 groups, but the viral load was very, very, very high in all children. And let's focus now on the causes of death. I will split this in underlying, comorbid, and immediate cause of death. Just remind that I was saying that we were trying to understand the chain of events. So this underlying cause of death is the lower part triggering other conditions. And complication of HIV was the most important cause of death in the two groups, with some difference. The most important was HIV resulting in wasting syndrome, but that was a bit higher among those dying after discharge compared to those dying in the first admission. Whilst those dying in the first admission, they have more HIV resulting in multiple infection or infection plus other conditions such as anemia or other conditions that were not infections. We have a high number of children that we couldn't determine the cause of death, around 18%, and most of them are because they die at home after discharge, and we didn't have any information to really understand well the cause of death. And we found a few cases during the first admission where HIV was not considered relevant in this case because the child was the first admission, CD4 were fine, the viral load was not very high compared to other children, and that was pneumonia was considered the major cause of death. When we go to immediate cause of death, pneumonia was the main cause of death in those dying during the first admission. That was somehow normal, expected, because those children were admitted because severe pneumonia, but among those dying after discharge, sepsis, clinical sepsis, not identified with any pathogen because we didn't do systematically blood culture, was more common among those dying after discharge. And pneumonia, anemia, tuberculosis, and gastroenteritis were the most common comorbid causes between the underlying and the immediate cause of death, but there were no difference between the groups. And this is the Sankey diagram, somehow showing how underlying morbid and immediate causes of death are interrelated each other. And if you see here, the dark red bar is the HIV complication. Most of those are related to morbid and immediate condition. And these morbid and immediate conditions are usually infectious diseases, sepsis, pneumonia, tuberculosis, and other infectious diseases. So I have shown many results. Just a summary, most of the children were new diagnosis with HIV with very high viral load. The time to death was 3 days in those dying in the first admission versus 78 days those dying after discharge. Young infants were more likely to die soon after admission. Pneumonia was the most common immediate cause of death among those dying during the first admission, and lower saturation was somehow a significant predictor. While sepsis was more common in those dying after discharge. The major underlying cause of death was complication of HIV, especially HIV resulting in wasting syndrome. Tuberculosis was an important contributor to death in around 20% of the cases, but always as comorbid condition, or most of the time as comorbid condition. And we couldn't find any cause of death in 18% of the children because they died at home. As some key message, infants living with HIV and pneumonia are at very high risk of die very soon after developing the pneumonia, and their care should be prioritized. Lower saturation and young infants could be good predictor of risk of dying at the time of admission when they have pneumonia. HIV wasting syndrome is a major underlying cause of death, and we should try to avoid somehow this problem in infants living with HIV. Sepsis is a cause of death in children after the first hospitalization, and that maybe could make us think that maybe the prophylaxis that the children are receiving is not preventing sepsis due to different microorganisms. Maybe we should try to think in what else we could give as a prophylaxis to those children. And tuberculosis is an important condition contributing to death in these children. I would like to thank to the EMPIRICAL Consortium, Pablo Rojo, the chief investigator, all our partners, all the families and participants that are agreed to be part of this group, all clinicians working and supporting EMPIRICAL. And that's all. Thank you.